Assalamu alaikum wa rahmatullah. Good afternoon, everyone. I'd like to thank the organizing committee for asking me to share with you these thoughts. I'm going to talk about management of high risk and very high risk patients. So when you talk about risk, what do you mean? We either have patients that present with disease. So if someone does present with atherosclerotic vascular disease, that person has already declared themselves to actually have the disease that you were trying to prevent in the first place. So by definition, that individual is a very high-risk individual. However, we see individuals who seek our advice and seek or do maybe a laboratory screening themselves, or they have family history and they want to be reassured whether they need to take medications or not. So here we need to use a tool that will assess the risk of that individual in order that we can give them scientifically based advice what they should do on whether they would benefit from taking any medication or following any lifestyle changes. So in our just published Saudi dyslipidemia guidelines, we made a recommendation, a class 1 recommendation for utilizing the score system for assessment of risk. We do not have today any tool that has been validated in our own population to actually assess the risk. However, we are advocating the use of the score system to assess the risk, and we do acknowledge that there is an urgent need to actually develop a risk scoring system specifically adapted for our population, and that we advocate the routine assessment of the score system for any individual who has not developed the disease and who's not diabetic, who has reached the age of 40, because this is where the evidence exists. And for those who are younger, we advocate just assessing risk factors serially. Now, to just talk about the score risk factor, or the risk tool, it's been developed specifically in Europe. It's been designed to give risk according to 4 risk regions. They are displayed on this map. You will see the green areas. These are low-risk regions of Europe. These are associated with 100 mortalities per 100,000 of deaths of population. Moderate risk, which is displayed in yellow, is associated with deaths between 100 to less than 150 cardiovascular deaths per 100,000 of population. High-risk areas are associated with mortalities between 150 to less than 300, and the very high-risk areas are associated with 300 deaths, CV deaths per 100,000 of population. Now, there is 2 score systems. There's the score system and the score 2 system. In our guidelines, we did not differentiate these 2. I personally find the score 2 system probably a better tool to be used. It's been developed to estimate the 10-year fatal and non-fatal risk of developing cardiovascular disease in people who did not have previous cardiovascular disease. So this it only applies for people that are not diabetic and have not yet developed atherosclerotic vascular disease. The score 2 is being adequately derived and validated in many cohorts with a large number of individuals of population and people who have developed the disease. And therefore, these have been really very validated scoring systems. They are not the only score systems that exist, but the score and the score 2 systems are really very well validated score systems. Both of them use five items. Four are exactly the same between the score and the score 2: age, sex, smoking, systolic pressure. The only difference between the score and score 2 is the score uses the total cholesterol, whereas the score 2 uses the non-HDL cholesterol, which is probably a better laboratory measurements of lipid, and therefore it's probably a better tool to use in day-to-day clinical practice. The diagrams or the charts are given, expressed in 4 charts: A for the low risk areas, B for the moderate risk area, C and D is for the high and very high risk areas. And they all follow the same format. Vertically, you see 6 age categories from 40 to 69. You also, on the left-hand side, you see the systolic blood pressure, and each two charts, one for men, one for women, and they will be categorized for smoking and non-smoking status. And on the horizontal axis at the bottom, you will see the non-HDL cholesterol, and therefore you can take the age of the individual, take their sex, take their systolic pressure, smoking status, and by knowing their non-HDL cholesterol, you can estimate then 10-year fatal or non-fatal CVD event. However, we have already seen from multiple registries done in the Gulf and Saudi Arabia that the mean age of presentation of acute coronary syndrome is around 10 years sooner than what people develop ACS in Europe. And for that reason, what we did not identify in our guidelines is which risk region should we consider ourselves. Unfortunately, we could not come to a consensus in the guidelines which of the risk regions we should assign ourselves. I personally would advocate that we use the red area, which is the very high risk areas, for the 2 reasons that I have, for 2 reasons. The first is that you see many of the Mediterranean countries that share with us a lot of food habits and a lot of lifestyle characteristics are included in the very high risk areas. And the second is the fact that, as I've just said, that we see ACS 10 years younger than European counterparts. And for that reason, I would say until we have our own validated data, we probably consider using the very high risk region when we, or the very high risk chart when we are assessing risk for an individual in this country. Now, that takes me to what is high and very high risk. Unfortunately, the projector is not very good, and therefore you do not see what does high and very high means. But very high, anyone who has developed atherosclerotic cardiovascular disease, whether they presented clinically, whether they have had a clinical event, or whether that is proven by imaging studies, they are considered very high risk. Additional people who are considered very high risk are those that have a risk score of 10% or more, or those that have familial hyperlipidemia, as has already been described, with another major risk factor, or severe chronic kidney disease indicating an eGFR of less than 30, or diabetes with target organ damage, or with 3 major risk factors, or really early onset type 1 diabetes and prolonged duration. The high risk individuals are those that have a risk between 5 and 10%, or markedly elevated single risk factors such as total cholesterol of 8 millimoles, or a total low density lipoprotein cholesterol of more than 4.9, or elevated blood pressure greater than 180/110, or a familial hyperlipidemia without other major risk factor, or moderate CKD with a creatinine between 30 and 59, or diabetes without target organ damage. This diagram, which actually is from our guidelines, is an important diagram for people to actually display in their office, because it tells you the target with which you need to treat an individual when they are at high risk or very high risk, or even when they have extremely high risk. This is a category that we have added to our guidelines for those that develop recurrent events when they are on treatment. And in each of these, we have given a target for therapy. And we have given targets for therapy for low-density lipoprotein cholesterol, for non-HDL cholesterol, and for ApoB, for those that do measure ApoB. And therefore, the LDL targets for the high-risk individuals, currently recommendation is that it should be below 70 milligrams or 1.8 millimoles, and for the very high-risk individuals, it should be no more than 55 milligrams per deciliter or 1.4 millimoles per liter. The question is, how do we achieve that? Very simple. You use statins. When required, you add ezetimibe. If you're not controlled, you add another agent, either a PCSK9 monoclonal antibody or the small interfering RNA molecules. But you need to achieve that target. What is more important is to actually see how are we doing in clinical practice? How far are we actually from achieving these targets? And I'll go very quickly in several studies that have been published from our area. The first one is the CEPHAS study, 2014, really shows using very old classification and very modest lipid targets by today's standards. These will not fulfill the criteria today, as I've just explained, for the very high or the high risk. Even for that, at that time, the very high risk was set to be only controlled in 31% and the high risk in 52%. The very high risk today would only be qualified as high risk, and the high risk would qualify as moderate risk. So we were not doing very well at all. In 2016, another publication came, and they classified their very high atherosclerotic cardiovascular patients. They stratified them according to the triglyceride level. Blue if the triglycerides was below 150, red if the triglyceride between 150 to 100, and green if the triglyceride is greater than 200. And for all of these, for the best category of triglyceride, the degree of achieving an LDL of 70, and this is 70 the target for very high risk. So today is only considered an acceptable target for high risk and not very high risk. The control was only 30%, and if you take the highest of the highest group, those with the high level of triglycerides, the degree of control of LDL to 70 milligrams was only 17%. And this is the control for the high risk group, which today we would classify as moderate risk group and not high risk group. So you can see that the control, if you take the ApoB, was merely 20% in those with the very high levels of triglycerides, all indicating really poor achievement of targets. The most recent of the publications was 2018, and this included very high risk patients because they all presented with ACS and they were all placed on lipid lowering therapy. And this was an observational study. After 4 months, of those that had a lipid panel requested, only 4.8% achieved an LDL of 1.8. So these are very high risk by today's standard. The target should be 1.4, in other words, 55 milligrams. So even taking the old targets, only 5% actually achieve that. So by today's standard, maybe 0% would be achieving that control. Is that something peculiar to us in Saudi Arabia and the Gulf? Well, I don't think so, unfortunately. This is a study from Europe, again, looking at high and very high risk individuals, and they've done a systematic review, lots of data, and what they found was that few patients at high or very high risk of CV events did achieve recommended LDL targets, and those that were at the highest of risk had the least degree of control. More importantly, this is a publication that just appeared in online. It's to be published in The Lancet in June. This is the Santorini study. This is an important really piece of publication indicating current control of lipid targets, with a prospective observational study that documented the use of lipid-lowering therapy in patients who are high or very high risk in primary and secondary care setting in European countries, included around 9,000 patients. The high risk were 2,637, and the very high risk, 6,400 patients. And how did they do? It's the second bar from the left-hand side. The second bar from the left-hand side, the green are those that are controlled to targets, blue are not achieving targets, and the gray at the top, the lipids were unknown. So amongst the very high risk, only 18.6% were actually controlled at target. 75% were not controlled, and 6% the lipids were unknown. If you look at the high-risk group, 24% were at target, 68% did not achieve targets, and 8% were unknown. Interestingly, 21% of those that were controlled were on monotherapy, and of those that had achieved target, 32% actually were on combination therapy. So people everywhere are not doing very well. What can be done to improve goal attainment? I'm going to go through three quick reviews. This is a survey that is being submitted for publication, that this is something that we have done here in Saudi Arabia. We've done a simple survey of 40 physicians in 4 medical centers. We've given physicians 10 hypothetical cases and asked them to actually solve these 10 cases. We scored them. After that, we gave them an educational program, and we gave them iPads that actually had prompts when they came to answer the same cases again after 3 weeks. So we did the baseline, and then each physician did the same cases after 3 weeks on an iPad that was dedicated with the educational program, and giving them prompts when they came to answer the same questions. What we found was that on the second survey, the scoring of the physicians improved by 75%. There was significant improvement between the first one and the second one, even though I would say if you were to assess a scoring by passing an exam, the initial score was somewhere around 55, and the repeat score was around 67, so not even achieving 70%. And that really told us that there is a big gap in knowledge, not only in the practice, but also in knowledge. And that's why we made this recommendation that we do need to disseminate the LDL treatment targets, that we do need to standardize targets. That has been done, target number 2, by the publication of the national guidelines. There is a need to organize more educational initiative to increase awareness of treatment target, and perhaps to consider integrating frequent reminders and warnings and risk factors in electronic health records. What has been done elsewhere, this is a publication from Yale about an ongoing trial called the Prompt Lipid. What they have done was an electronic health-based trial to assess the effectiveness of a real-time targeted health alert embedded in the electronic health system with ordering capability to promote lipid-lowering therapy intensification. And the implication of this study is that the findings from this low-cost, widely scalable intervention could potentially improve the LDL and have an important health implication. In the first 7 weeks of this study, they managed to recruit 50% of their target population, and they have not yet published their final result, but interestingly, out of these 1,250 patients, only 71% of them were on statins, only 9% were on combination with ezetimibe, and only 3% were on PCSK9 inhibitors. We await the full result of the study. Perhaps one of the most useful resource for pharmacists and physicians is this review, which is also published in 2022, based on UK practice. And what they've tried to analyze in this paper is the possible causes for failure to meet cholesterol goals and what could be the possible solutions. They've come up with 6 different causes why perhaps we are not achieving the targets: underdosing of statins, treatment initiated late, the adherence issues related to intolerance versus reluctance by the patient or the physician, lack of systematic follow-up, and finally, the lack of response when there is an inadequate response to statin and ezetimibe or their combination. And I would really strongly recommend anyone who's having a lipid clinic or a program to actually go through this paper, because it has a lot of concept and a lot of ideas and a lot of things that people can actually incorporate in their day-to-day clinical practice to help them improve their goal attainment. I'd like to stop here, and I'll be happy to answer any questions raised during the question Q&A.